Welcome back to Rad Onc's Smart Review, Thoracic Edition.
Glad to be here. Ready to get into it.
Yeah, so today we're tackling something that, you see this in clinic all the time.
Oh, constantly, every week.
Right, so imagine you're sitting in clinic, you're looking at a fresh set of scans for your patient, and they feel completely fine.
Totally asymptomatic.
Exactly. They're non-small cell lung cancer. It hasn't grown in months. They're tolerating systemic therapy just beautifully. But suddenly there's this single glowing spot that just popped up on their adrenal gland.
Yeah, the classic solitary progression.
Right. So the question for you, the listener, is do you fire up the linear accelerator and just blast it? Or, are you just playing this incredibly expensive game of whack-a-mole?
Right. Like, are you just delaying the inevitable realization that their systemic therapy has completely failed?
Exactly.
It really is, it's the central dilemma in modern thoracic oncology right now. Because we aren't really asking if the radiation can control the lesion anymore.
Right. The technology is there.
Yeah. Yeah, from a purely mechanical standpoint, stereotactic body radiation therapy, SBRT, it can ablate almost any localized target you point at.
Yeah.
The engineering is totally there.
Yeah.
The much harder problem, the biological problem, is deciding what that radiation is actually trying to accomplish.
Right, because this patient has already proven beyond a shadow of a doubt that their disease has the machinery to spread through the bloodstream.
Exactly. So if you're listening to this on your commute right now, just think about how tempting it is to just count the spots on the scan.
Oh, it's so tempting. Like 2 spots, let's treat them. 10 spots, palliate them.
But we need to establish a core truth right out of the gate here. A lesion count is not a diagnosis.
The lesion count was not a diagnosis. I love that.
It is the single most important concept to internalize today. Let's look at the biology. You could have one patient with, say, 3 metastatic sites that have slowly evolved over 2 years of, really durable systemic control.
Right.
That patient might be a fantastic candidate for local therapy because their disease tempo is just incredibly indolent.
While another patient, they could have that exact same number of lesions, 3 spots, but those spots just erupted out of nowhere in like the 6 weeks between their scans.
Precisely. That second patient doesn't have oligometastatic disease just because the number is small today. They have rapidly disseminating explosive disease.
Yeah, and if you spend 3 weeks planning SBRT to chase those 3 spots, you're completely ignoring the biological reality.
Right. Microscopic seeds are already taking root everywhere else. Your local treatment isn't going to meaningfully alter their natural history. It's just going to give them fatigue and, pneumonitis.
It feels a lot like the difference between looking at a photograph versus watching a movie.
Oh, that's a great way to put it.
Because the lesion count, that's just a photograph. It gives you a static number, but it tells you absolutely nothing about the velocity of the disease.
That is exactly right. And to really cement this for the listener, let's ground today's discussion in a concrete scenario.
Okay, let's do it.
We have an anchor case to walk through that's going to test really every one of these concepts.
Perfect. So let's set the stage for you. You have a patient in front of you with excellent functional status. They have biopsy-proven non-small cell lung cancer.
Okay, classic presentation.
Right. You've completed the full staging workup, which shows a thoracic primary, some involved regional nodes, 1 adrenal deposit, and 1 osseous deposit.
Okay, and we absolutely need to confirm the status of the central nervous system here. What does the brain MRI show?
Clean. No intracranial disease whatsoever.
Good.
Now, one of those distant sites has pathologic confirmation. Let's say we biopsied the adrenal gland and it matches the thoracic primary.
Right.
The other distant site, the osseous lesion, it's radiographically convincing on the PET scan, but it hasn't been sampled with a needle.
Got it. And what about their systemic journey so far?
So molecular and protein testing have been completely reviewed with MedOnc. The patient went through initial systemic therapy and the response was excellent. We have solid disease control.
No new lesions.
No new lesions. And critically, looking at the anatomy, the thoracic disease and both metastatic sites appear technically amenable to definitive local treatment.
Okay, so they're safe to treat.
Right. So here is the consult question we're wrestling with today. Should systemic therapy continue alone, or should this patient receive definitive local treatment to every known site?
Well, before we even pull up a clinical trial or, talk about dose constraints, we have to establish the vocabulary.
The vocabulary, right.
We have to define exactly what state this patient is actually in. The language we use in the chart isn't just semantic decoration. It actually defines the underlying biology.
So what are the terms we need to lock down?
We have to separate all site consolidation from resistant site ablation.
Okay, break that down for me because honestly, I hear those terms thrown around interchangeably in tumor boards all the time.
Yeah, people confuse them, but they're completely different strategies. So
Yeah.
all-site consolidation applies to synchronous, limited metastatic disease that has not progressed. You're treating the thoracic primary, any involved regional nodes, and every clinically relevant metastatic site. And you're doing this after initial systemic therapy has shown that the disease isn't rapidly progressing.
So you're taking a patient who's responding well, and you're trying to consolidate that response by eradicating the visible macroscopic disease.
Exactly. The whole body is responding, or at
Yeah.
least stable, and we were sweeping up the remainder.
Okay, so how does that contrast with resistant site ablation?
Resistant site ablation happens in the setting of oligoprogression.
Right.
This is when a patient is on an active systemic regimen, most of their body is controlled, but a limited number of sites have genetically mutated to escape that specific drug.
Oh, so the goal there is entirely different.
Totally different. You are not trying to cure them or consolidate a global response. You're basically acting as a sniper.
A sniper. I like that.
Yeah, you're taking out the specific resistant clones so that the medical oncologist doesn't have to abandon a systemic drug that is still working for like 90% of the patient's body.
The intent changes everything. I mean, the
Right.
stereotactic machine is the same, the beams are the same, but the consent discussion you have with that patient is just night and day.
Absolutely. And let's take it a level deeper into the vocabulary of the disease states themselves.
Okay.
Our anchor case is synchronous oligometastatic disease because the metastases were present at the time of initial diagnosis.
Great. They showed up on the very first scans.
Right. But what if they were metachronous?
So that would mean the metastases appeared after a period of being disease-free, right?
Yep.
Like following prior definitive treatment.
Yes.
Like, say, someone who had a lobectomy for a stage 1 cancer 3 years ago, and now, boom, they have 2 bone spots.
Exactly. And think about the biological implication there. Metachronous disease often suggests a much more indolent, slow-moving natural history. The cancer took 3 years to show its face again.
Right, that's vastly different from someone who progresses in 3 months.
Totally.
Yeah.
Compare that metachronous state to induced or oligoresidual disease.
Okay, what's that?
That's where a patient presented with widespread, massive metastatic burden, and the systemic therapy melted it down to just 2 visible spots.
Oh, wow. Yeah, I would be terrified of that induced oligoresidual patient. I mean, even if the scan only shows 2 spots today, you know for a fact that this specific cancer has the biological machinery to disseminate everywhere.
Right.
Those 2 spots are just the visible survivors of a massive army.
And that is exactly why universal metastasis count is a trap.
Okay, let me play devil's advocate here, though.
Go for it.
If you look at the major clinical trials, they literally use hard cutoffs.
Oh.
The Gomez trial used 1 to 3 metastases. The Iyengar trial allowed up to 5.
Yeah.
The Seber-Comet trial had strict numerical limits. So if the world's best researchers are using a metastasis count to define who gets treated, why shouldn't a listener just use a cutoff of 3 or 5 in their own clinic?
It's a fair question, but trial limits are study designs. They're not laws of nature. They're statistical boundaries drawn to ensure a trial can actually accrue patients and achieve statistical power. They tell us which populations generated the evidence, which is vital. But there is no biological switch that suddenly flips between metastasis number 4 and metastasis number 5.
Right, so 4 lesions aren't inherently favorable just because they fit under a trial's cutoff of 5.
Oh, background.
So if the number of circles on the scan isn't the deciding factor, what is the framework? Like, how do we know if a patient actually has favorable biology?
You have to view their initial systemic therapy as a biological stress test.
A biological stress test. I love that framing. Walk me through how that actually works in practice.
So when a patient presents with synchronous metastatic disease, you don't rush them to the radiation vault on day 1. You start them on systemic therapy.
Right, you get drugs on board.
And that period of systemic treatment acts as a filter. If their disease is highly aggressive and rapidly mutating, it will explode on that first interval scan.
You'll see new spots in the liver, the brain, the bones.
Exactly. By waiting and testing the biology with drugs first, you just save that patient from unnecessary, toxic, and ultimately futile local radiation.
But if they come back after, say, 3 months of systemic therapy and everything is stable or shrinking, they pass the stress test.
Exactly. They have demonstrated a biologically favorable tempo. You've proven that you aren't just chasing a runaway train.
Bringing this back to our anchor case, This patient passed the stress test. They had initial systemic therapy. There are no new lesions, and disease is controlled. So are we ready to draw contours?
Not yet. A local therapy decision is only as robust as the disease map, and creating that map requires absolute rigor.
Let's talk about that rigor. So a PCT is practically mandatory here to define the extracranial disease, right?
Yes, absolutely. A standard CT scan is simply not sensitive enough to definitively rule out occult bone or lymph node metastases when you're considering an aggressive, potentially toxic consolidative strategy.
You need to know exactly what you're dealing with. And then there's the brain MRI. I want to camp out here for a second because it is such a critical failure point.
It really is.
I've seen situations where a patient gets a PET scan, it shows 3 spots, and the team starts planning SBRT before the brain MRI is even scheduled.
That is conceptually backwards. Occult intracranial disease completely changes the math. It changes the site count, the sequencing of treatments, and the prognosis.
That's just the rule.
The rule is an incomplete brain evaluation makes an extracranial consolidation plan conceptually incomplete before a single contour is drawn.
Right, because if they have 6 asymptomatic brain metastases that you don't know about, blasting their adrenal gland with 50 gray is functionally meaningless for their survival.
Exactly.
You're treating a symptom that doesn't exist while ignoring the thing that is actually going to threaten their life.
Precisely. Now, let's look at the pathology in our anchor case. We have one pathologically proven distant site in the adrenal gland, but we have that unbiopsied osseous lesion. Does it need a needle in it?
This is where clinical judgment gets really muddy. Like, when do you actually force a patient to undergo a painful bone biopsy?
You only pursue pathology if it answers a question that will actually change your management.
Okay.
To figure that out, we use the 6-question lesion ledger. It's a brilliant mnemonic stride. Every radiation oncologist needs to run every single lesion through this ledger.
STRIDE. Okay, let's run our unbiopsied bone lesion through STRIDE. S stands for strategy.
Right. Does treating this specific bone lesion support our overall strategy of all-site consolidation? Yes, because leaving it untreated would mean we're abandoning the consolidative intent.
Okay, that makes sense. T is for tissue. Does this lesion need tissue to change management?
This is the tricky one. If the patient have a known primary lung cancer, a proven adrenal met, and this bone lesion lit up bright on the PET scan with obvious destructive changes on the CT, it is overwhelmingly likely to be a metastasis.
Right, so a biopsy might just introduce procedural risk without changing our plan at all.
Exactly. But what if it was a solitary rib lesion with no adrenal met? What if finding out it's benign would completely move the patient off the metastatic pathway and back to a stage 1 curative pathway?
Oh, then you absolutely need tissue.
Yes. The context dictates the necessity.
Okay, moving on. R stands for related.
Is it likely related to the lung cancer? Could it be a second primary? Could it be myeloma? You have to ask.
Right, then R is for intent. Can it be treated with durable local intent?
If the bone lesion is massively invading the spinal canal, durable local ablation might be impossible without paralyzing the patient. So you have to know what you can actually achieve safely.
D stands for disrupts. Does it threaten function or structural stability?
If that osseous lesion is eating through the cortex of the femur, the patient might need a prophylactic orthopedic rod placed before we even think about radiation.
Right, otherwise the bone will snap the next time they stand up.
Exactly.
And finally, E is for evidence. Is there evidence it is malignant versus just benign inflammation?
So that's STRIDE. Strategy, tissue-related, intent, disrupts, evidence. You have to ask all 6. The weakest, most dangerous answer you can put in a chart is, it lights up on piece, you're going to SBRT it.
You really have to state your diagnostic uncertainty explicitly.
Always.
Okay, let's say we've run STRIDE on an anchor case. The brain is clear. The staging is immaculate. The bone lesion is clinically malignant, structurally stable, and safely treatable. We are committing to all-site consolidation.
Okay.
What is the actual evidence that this helps the patient?
Well, we have to look at the foundational evidence duel here. On one side, we have the classic randomized phase 2 trials, Gomez and Iyengar.
Yeah, I'm looking at the Gomez numbers right now, and honestly, they look almost too good to be true.
They were striking.
I mean, they took 49 patients with 1 to 3 metastases who hadn't progressed on first-line treatment. They randomized them to maintenance therapy versus local consolidative treatment. The median progression-free survival literally tripled from about 4 months in the control arm to 14 months with local treatment.
Right.
And median overall survival more than doubled 17 months versus 41 months. What is the catch here?
The catch is the era in which the trial was conducted. It was a brilliantly designed study, but it was small. It closed early for a progression-free survival signal, which, can sometimes mathematically exaggerate the effect size.
Right, small numbers can look huge.
Exactly. But most importantly, it was conducted before contemporary immunotherapy became the standard of care for first-line treatment.
Ah, so the control arm in Gomez was getting older chemotherapy maintenance, not the highly effective PD-L1 inhibitors we use today.
Yes. And the Iyengar study showed a similar massive benefit. Progression-free survival jumped from roughly 4 months to 10 months. But again, it was a small study in the pre-immunotherapy era.
So what did those trials actually prove then?
They proved the biological plausibility that local ablation can alter the natural history of the disease. But they do not automatically prove that we should apply that exact same aggression to patients receiving modern systemic drugs.
Which brings us to the modern counterweight, right? The trial that throws a massive wrench into this whole philosophy, NRG LU002.
Yeah. LU002 is the trial that forces every thoracic oncologist to just pause. It was a phase 2-3 trial in the modern era. 215 patients, no progression after first-line therapy, maximum of 3 extracranial metastatic sites.
Okay.
And crucially, most of these patients were receiving modern immunotherapy-containing regimens.
And the results were completely sobering. I mean, the progression-free survival hazard ratio was BA93. The p-value was 0.66. It didn't even meet the threshold to proceed to the phase 3 portion.
Right.
1 year progression-free survival was basically identical. It was roughly 48% with local therapy versus 52% with maintenance therapy alone. No overall survival advantage.
And honestly, the efficacy isn't even the most concerning part of LU02.
Really? What is?
It's the toxicity. Grade 3 or higher pneumonitis was reported in 10% of the patients getting local consolidative therapy, compared to only 1% in the systemic therapy alone.
Wait, I need to understand the mechanism there. Why does adding radiation to a patient who is already on immunotherapy cause a 10-fold increase in severe lung inflammation? Is it just the physical radiation dose?
No, it's a profound biological interaction. When you use SBRT, the high dose of radiation causes massive, rapid tumor cell death.
Okay.
This necrotic cell death releases a flood of tumor antigens and what we call danger-associated molecular patterns, or DAMPs, into the tumor microenvironment.
It's like ringing a dinner bell for the immune system.
Exactly. Now, normally the immune system might be suppressed by the tumor, but this patient is on an immune checkpoint inhibitor, like a PD-1 or PD-L1 inhibitor.
Right, the drug has taken the brakes off the T cells.
Right, so you have a flood of new antigens combined with an artificially hyperactive immune system. In the delicate alveolar tissue of the lung, this dual hit can trigger a massive cytokine storm.
Wow.
The immune system doesn't just attack the tumor, it causes severe diffuse inflammation of the healthy lung tissue.
That perfectly explains the 10% grade 3 pneumonitis. Because, grade 3 means they are requiring oxygen, high-dose steroids, maybe hospitalization. You're causing serious harm.
Yes.
So looking at LU002, does this mean we just abandon all site consolidation completely in the immunotherapy era?
No, we don't abandon it, but we can no longer present it to patients as a guaranteed benefit. LU002 had its own limitations. The population was heterogeneous. Some patients had a massive initial disease burden that shrank down that induced state we know is higher risk.
Right, so maybe the wrong patients were in the trial.
Perhaps. But you cannot wave away a negative randomized trial. It means routine consolidation requires incredibly careful patient selection.
What about patients whose disease is driven by a specific genetic mutation, like an EGFR mutation?
That is a totally different biological landscape. Look at the CINDUS trial. This looked at patients with EGFR-mutated disease taking a first-generation tyrosine kinase inhibitor, or TKI.
Okay, what happened there?
Adding upfront radiation to all sites improved progression-free survival from 13 months to 20 months and overall survival from 18 to 26 months.
That's a huge difference. Why does radiation work so much better alongside a targeted TKI compared to immunotherapy?
It comes down to how resistance develops. With targeted therapies like TKIs, resistance often develops through clonal evolution. A specific subclone of the tumor develops a secondary mutation like T790M that prevents the drug from binding.
Oh, I see.
Yeah, so if that resistant subclone only develops in 1 or 2 macroscopic spots, radiating those spots physically eradicates the resistant cells. It essentially resets the biological clock, allowing the TKI to continue suppressing the sensitive microscopic disease everywhere else.
That is fascinating. The mechanism of resistance dictates the utility of the radiation.
Exactly.
So, knowing all this, the Gomez optimism, the LU002 pessimism, the EGFR nuance, how do you actually sit in the room with our anchor case patient and explain this without completely confusing them?
It's tough, but you have to separate the established mechanical facts from the uncertain biological benefits. I would look at the patient and say, your current medication is doing an excellent job controlling the microscopic cancer cells floating in your bloodstream. The radiation we're discussing would add focused, high-dose beams to every visible spot in your scan. We know for a fact that radiation is very good at destroying the specific spots we aim at.
Okay, so you establish the local control benefit first.
Right. Then I lay out the data duel. I say, earlier studies show that doing this might delay the cancer from growing and could help selected patients live longer. However, more recent, larger study using the modern immune drugs you are taking did not clearly show that survival benefit, and it did show a real risk of causing severe inflammation in your lungs.
That is incredibly transparent. You aren't hiding the toxicity at all.
You can't. And then you frame the ultimate trade-off. The potential upside is extending the time before the cancer grows again. The downside is the fatigue, the risk to your healthy lung tissue, the need to pause your systemic medication, and the reality that microscopic seeds we can't see may still grow, regardless of what we do with the radiation.
That counseling perfectly shifts the burden of decision-making. You're offering it as a multidisciplinary option, not an absolute mandate.
Exactly. Now let's throw a wrench into our anchor case. Let's introduce the first twist.
Ooh, okay. I'm ready.
Our patient has been on their systemic regimen for 8 months. The thoracic primary is stable, the bone lesion is stable, their brain is clear. But on the latest scan, the adrenal lesion has grown from 2 centimeters to 3.5 centimeters. Nothing else has changed.
This completely rewrites the intent. We are no longer talking about all-site consolidation. This is the definition of oligoprogression.
Yes. The systemic drug still works for the chest, the bone, and the microscopic disease. The goal here is resistant site ablation. We want to eradicate that specific adrenal clone that has figured out how to evade the drug.
And the clinical endgame here isn't necessarily a cure, right? It's buying time. Because
Yeah.
if we don't ablate the adrenal gland, the medical oncologist will be forced to declare the current systemic drug a failure.
Right, and then switch the patient to a second-line therapy, which might have worse side effects or a lower chance of working.
Exactly. We are trying to extend the runway of the current effective systemic drug, but this is where you have to be incredibly paranoid about chasing lesions.
You really do.
How do you know for sure it's isolated oligoprogression and not just the beginning of a total systemic collapse?
You have to interrogate the serial imaging. A single snapshot showing adrenal growth is not enough. You need to look back at the last 3 scans. Are there tiny sub-centimeter nodules in the liver that look a little fuzzier today than they did 3 months ago? Is the patient losing weight? Are there tumor markers climbing? If multiple organ systems are starting to simmer, that is global systemic resistance.
And if it is global systemic resistance, radiating the adrenal gland is just a distraction.
It's worse than a distraction. It actively harms the patient by delaying the switch to a new systemic drug that might actually regain control of the whole body.
So what is the evidence for jumping in and radiating these oligoprogressive spots?
The data is a mixed bag that really demands nuance. We have the CURB trial. This was a randomized phase 2 study looking at patients with limited progressive sites in breast cancer and non-small cell lung cancer.
I recall the lung cancer cohort did really well here, right?
They did. For the non-small cell lung cancer patients, standard of care alone gave a median progression-free survival of about 2.2 months. Adding radiation to the progressive sites boosted that to 10 months.
Wow, that is a massive clinically meaningful delay before the next progression event.
It is. But didn't the breast cancer cohort in that same trial show 0 benefit?
Wait, really?
Oh.
0.
0 benefit. Which proves that resistant site ablation is highly dependent on the underlying histology and biology of the cancer. You cannot apply a lung cancer success story to a breast cancer patient without skepticism.
That makes total sense. And then there is the ESTA-AP NSCLC trial, which I think is the perfect cautionary tale here.
It really is. ESTA-AP NSCLC looked at patients with limited progressive metastases. They found that stereotactic radiation definitely improved local control of the specific lesions they treated. But here's the kicker. There was no clear progression-free or overall survival advantage compared to standard care.
The survival curves actually crossed, didn't they?
They did.
That is a critical distinction for the listener. Better local control of the adrenal gland does not automatically prove that you have altered the overall trajectory of the patient's life.
Exactly. So let's say we have vetted the biology, we agree it is true oligoprogression in the adrenal gland, and we are going to treat it along with the stable thoracic primary. How do we physically do this safely?
Let's move to the planning workstation.
Yes, let's do it.
The first thing you emphasize in the source material is the necessity of a written target inventory. Why is writing it down so critical? I mean, we're looking right at the scans.
Because a clinical failure happens long before a dosimetric failure.
What do you mean?
If your intent is comprehensive consolidation, and you map out the primary and the bone lesion, but you forget to contour the involved mediastinal lymph nodes, you have failed the entire biological strategy.
Right.
A written inventory listing every primary site, nodal basin, metastatic site, and explicitly noting which are being treated and which are being observed prevents cognitive errors.
Okay, the list is written. Now we move to CT simulation. Our anchor case has a tumor in the lung and a tumor in the adrenal gland. They're both in the torso. Can we just use the same 4D respiratory motion strategy for both?
Absolutely not.
Right.
And understanding why requires looking at the biomechanics of breathing.
Break down the physics of it. Why don't they move together? They're inches apart.
The lung expands three-dimensionally, radially from the hilum. A tumor in the upper lobe of the lung might move a few millimeters anteriorly and posteriorly. But the adrenal gland sits retroperitoneally, perched just above the kidney, right beneath the crust of the diaphragm.
Oh.
When the patient takes a deep breath, the diaphragm acts like a massive piston. It shoves the liver, the kidney, and the adrenal gland severely inferiorly.
So the vectors of motion are entirely different.
Completely different. If you use a single internal target volume, an ITV based on the lung tumor's motion, and assume the adrenal is doing the exact same thing.
Your radiation beam might completely miss the adrenal gland when the patient exhales.
Exactly. You have to evaluate and manage the motion for each target independently.
That is a terrifying dosimetric miss if you aren't paying attention.
It is.
Let's talk about target hierarchy in serial organs. This is a classic dilemma. Imagine the adrenal lesion and the bone lesion are easy. They're far away from anything critical, but the thoracic primary tumor is abutting the proximal airway or the esophagus. To get an ablative tumor-killing dose to that lung mass, the planning system shows you are going to violate the safety constraints for the esophagus. What do you do?
The rule is absolute here. Serial organ safety sets the ceiling. You do not force a high-dose peripheral prescription onto a high-risk central target if it violates credible safety limits.
Because what happens if you burn a hole in the esophagus?
You cause a grade 4 tracheoesophageal fistula. The patient aspirates everything they swallow into their lungs, they develop mediastinitis, and they likely die from the complication, not the cancer.
Wow.
The source text puts this brilliantly. The phrase, "every site must be treated," does not authorize an unsafe plan.
So if a listener is faced with this in clinic, how do they pivot? Do they just drop the dose on the central tumor?
You have to reassess the whole strategy. Can you change the fractionation? Instead of 5 fractions of SBRT, maybe you use 15 fractions of hypofractionated radiation to allow the healthy esophageal tissue time to repair between daily doses.
Or can you use a different modality, like proton therapy? And if you just decide to drop the dose to a non-curative palliative level for that central tumor to protect the esophagus, you have to admit to yourself that you are no longer doing all-site consolidation.
Right. You are doing selective cytoreduction. You changed the intent in the chart, and you change the expectation for the patient.
What about the systemic drugs while we were doing all this? Do we just hold the targeted therapy for like 5 half-lives?
Never invent a drug washout rule from memory. There is no universal rule. Some TKIs have a half-life of hours. Some immune checkpoint inhibitors have a biological effect that lasts for months.
And some drugs cause severe radiation recall or sensitize the bowel to perforation, right?
Yes. So you have to pick up the phone and call the medical oncologist and the clinical pharmacist.
You coordinate the hold interval based on the specific drug, its marrow toxicity, wound healing effects, and the urgency of the radiation. And you document exactly who is responsible for restarting the drug after radiation is complete.
Exactly. Communication is everything.
Okay, the plans are approved, the esophagus is safe, the drugs are held, the patient is practically on the treatment table. Let's introduce the second case twist, biology bites back.
Oh, this is the scenario every radiation oncologist dreads.
So during the 2 weeks it took to simulate and plan this complex multi-isocenter treatment, you ordered a repeat staging PT scan just to be perfectly thorough.
Okay.
That new scan comes back and it reveals 3 brand new lesions in the liver and a new spot in the contralateral lung that were not there a month ago.
Stop the train immediately. This is recommendation-changing information.
But the contours are drawn. The physicist spent hours optimizing the dose. The patient is sitting in the waiting room right now.
It does not matter. The biology has changed, so the intent must change. This patient is no longer exhibiting oligoprogression. The appearance of multiple new lesions in new organ systems over a span of a few weeks is the definition of rapid global systemic resistance.
Right. So if you proceed with treating the adrenal gland in the chest now, you are ignoring the blazing fire in the liver.
It's exactly. Proceeding with the SBRT plan now would subject the patient to the fatigue and toxicity of radiation while offering absolutely zero survival or systemic benefit.
So what's the next step?
You stop, you restage, and you send them back to medical oncology to change their systemic drug. The hardest thing to do in oncology is to walk away from a beautiful treatment plan, but sometimes it is the only ethical choice.
That is a tough conversation to have with the patient, but you're right. Okay, let's lock all this conceptual logic in for the listener. Let's run a rapid review and board blitz. I'm going to act as the oral board examiner, and I want to see how you navigate the classic traps.
All right, let's do it. Put me in the hot seat.
Before we get to the specific scenarios, what are the 3 fatal traps a candidate must avoid when discussing oligometastatic lung cancer?
Trap number 1 is declaring a universal lesion cutoff. If you look at a scan and say, the patient has 3 metastases, therefore this is oligometastatic and I will treat all sites, you fail.
Because it ignores the disease tempo and the completeness of staging.
Right. You must describe the biological state, the response duration to systemic therapy, and whether the sites can be treated safely.
What's trap number 2?
Trap number 2 is calling partial treatment all-site consolidation. If you ablate a convenient bone met but leave the active primary lung tumor untreated because it's too close to the esophagus, you cannot cite the Gomez trial to justify your treatment. That is selective palliation.
And trap number 3?
Treating oligoprogression without proving the systemic regimen still has value elsewhere. If you assume any limited progression deserves SBRT without checking serial imaging to confirm the rest of the body is controlled, you're just delaying a necessary switch in systemic therapy.
Excellent. Okay, listener, you are in a hot seat now. I'm going to hand you 3 clinical charts. Try to formulate your answer before the expert breaks it down. Ready? Scenario 1. You have a patient with metastatic non-small cell lung cancer. Complete staging, including a brain MRI, is perfectly clean. They have had no progression after initial systemic therapy. They have 3 known disease sites, a thoracic primary, involved regional nodes, and 2 extracranial metastases in the bones. Every single site can be treated safely.
Okay.
Do you A, treat only the easiest bone met because any local control is sufficient? B, present comprehensive local treatment to all sites as a multidisciplinary option, balancing the favorable Gomez data against the negative LU002 data? Or C, state that consolidation is absolutely mandatory because they have fewer than 5 metastases?
The only defensible answer is B. You have a coherent all-site consolidation question because the staging is complete, they passed the systemic stress test, and the anatomy is safe. But it is an option, not a mandate, because the evidence is heavily mixed across different eras and immune therapy populations.
Right. Choice A is partial treatment, which has no proven survival benefit, and choice C relies on a rigid numerical threshold and ignores the modern toxicity signals from LU002. Okay, scenario 2. You are proposing a multi-site SBRT course for 2 peripheral bone mets and a central thoracic target. The peripheral plans look beautiful, but the thoracic target is abutting the proximal airway. To hit your target dose, you have to drastically exceed the safety limits for the airway.
The classic serial organ problem.
Exactly. Do you A, accept the plan because every target must get the full ablative dose to count as consolidation? B, increase your setup margins to blur the dose? C, stop and reassess fractionation or abandon the consolidative strategy? Or D, just leave the thoracic target untreated but tell the patient they are getting all-site consolidation?
The answer is C. Serial organ safety sets the ceiling. You reassess fractionation, maybe moving to 15 fractions, or you abandon the strategy entirely. Choice A guarantees a catastrophic complication like an airway necrosis. Choice B is technically absurd. Blurring the dose by increasing setup uncertainty just ensures you miss the tumor and hit the healthy tissue anyway. And choice D is lying about your intent.
Great explanation. Last one, scenario 3. Your patient is on an effective systemic regimen. Everything is stable except one enlarging adrenal lesion. You diagnose oligoprogression. But during planning, a repeat scan shows 3 new liver lesions.
Oh, biology bites back.
Yep. Do you A, treat the adrenal gland anyway because that was the original plan, B, treat the biggest new liver lesion, or C, stop the radiation, restage, and tell medical oncology the systemic drug has failed?
Answer C. The biology changed. New lesions in multiple organs destroy the diagnosis of isolated oligoprogression. It is now global resistance. You stop the radiation and change the systemic drug.
Fantastic. To wrap this up, let's fire through the 6 clinical pearls. These are the fundamental takeaways you can write on an index card and keep in your pocket on clinic day. I'll read the pearl. You give the quick summary. Pearl 1, name the intent before the technique.
You must distinguish whether you are attempting all-site consolidation of a global response or resistant site ablation of an isolated escaping clone. The strategy dictates the setup.
Pearl 2, a numeric metastasis threshold describes a trial population.
It does not replace biological selection. Tempo, response duration, and safety matter infinitely more than whether the spot count is 3 or 4.
Pearl 3, consolidation is coherent only when the thoracic disease and every clinically relevant metastatic site are treated or explicitly accounted for.
If you leave active disease behind, you are doing palliative cytoreduction, not consolidation.
Pearl 4, favorable pre-immunotherapy phase 2 trials support consolidation.
But the negative modern randomized signal and the 10% severe pneumonitis rate from NRG LU002 prevents us from presenting it as a universal risk-free standard today.
Pearl 5, oligoprogression is fundamentally a resistance problem.
Local therapy is only compelling when the current systemic regimen still actively controls the vast majority of the microscopic disease, and all progressing sites can be safely addressed to extend the life of that drug.
Pearl 6, central anatomy, cumulative parallel organ exposure, prior radiation, and systemic treatment interactions can veto a conceptually attractive plan.
Just because the biology makes sense does not mean the physics are safe. Serial organ safety sets the ceiling.
The durable framework here is simple to state, but incredibly difficult to execute in the messy reality of the clinic. You have to map the disease completely, interrogate the biological tempo, decide if every site can be treated safely, coordinate deeply with your systemic colleagues, and always document your uncertainty.
Right, so much of our job isn't just knowing how to target the tumor, but correctly identifying what biological state that tumor is currently in.
Get show notes and complete practice oral boards at radonsmartlearn.com and subscribe for our next episode. Thanks for tuning in.